Welcome to Diagnostic Imaging's weekly scan. I'm Whitney Palmer, Senior Editor. We're back with you this week with the latest updates on the COVID-19 outbreak and its impact on the radiology industry. This week, the American College of Radiology hosted an expert panel and published guidance in the Journal of the American College of Radiology about how you can best prepare to reopen your offices and facilities to non-emergent imaging. They touched on many aspects of maintaining both your safety and that of your patients. For safety precautions, they suggested screening protocols for patients and anyone entering your building, strategies for the best use and allocation of personal protective equipment, and social distancing. In addition, they suggested a categorization system to help you determine which postponed imaging scans will be the most important to tackle first, as well as changes you can implement to your workflow that can help you process the backlog of imaging studies waiting for you. Although chest CT and chest X-ray have been widely discussed as the preferred imaging modalities for the COVID-19 pandemic, researchers from the Yale School of Medicine discussed reasons to opt for point-of-care ultrasound instead in the journal Academic Emergency Medicine. Not only can implementing ultrasound at the bedside help rule out other possible pulmonary diseases, but it can also facilitate better venous access and pinpoint additional cardiac complications. And if one clinician wears the appropriate personal protective equipment, disinfects the machine between scans, and navigates between patients, the risk of COVID-19 transmission can be better controlled. Overall, they said, the findings gathered from point-of-care ultrasound can be beneficial clinically, no matter the results. This viral outbreak is, without a doubt, the most significant health event of our lifetime. However, it's not the first time our global society has been threatened with a highly contagious virus. And according to experts in the field, there are lessons that radiology leadership can learn from those past pandemics that can lead to greater success today. In the Journal of the American College of Radiology, investigators outlined takeaway messages that can bolster the response your practice or center has to the outbreak. They advocated for clear, concise communication of necessary information, expressing gratitude to frontline staff rather than praise, maintaining an attitude of compassion for personnel who made unintended errors during this stressful time as well. The larger conversation this week about opening various parts of the country was also a reminder that there are still other aspects of radiology that are important to monitor. In a contributed column to Diagnostic Imaging, Dr. Susan Harvey, Vice President of Global Medical Affairs, Breast and Skeletal Health Division for Hologic Incorporated, shared guidance on the impact that artificial intelligence tools has had and will continue to have on mammography. In addition to improving breast density assessment and reducing the size of imaging vials, she pointed to future benefits in greater detection and the development of new risk models as advancements on the horizon. But back to COVID-19. This week, Diagnostic Imaging had the opportunity to talk with both Dr. Brian Coley, Radiologist in Chief at Cincinnati Children's Hospital, and Dr. Anthony Gabriel, Chief Operating Officer for Radiology Partners, about the role of teleradiology and its impact on pediatric imaging during the pandemic. They discussed the ways teleradiology has helped accommodate imaging and study interpretation for the youngest patients, as well as the long-term implications these changes might bring about. Here's what they had to say. Welcome to Diagnostic Imaging. I'm Whitney Palmer, Senior Editor. We are joined today by Dr. Anthony Gabriel, Chief Operating Officer of Radiology Partners, and Dr. Brian Coley, Radiologist in Chief at Cincinnati Children's. Dr. Coley is also a member of Radiology Partners. They are with us today to discuss the role teleradiology has played during the COVID-19 pandemic, as well as what the future might hold for such services and the impact on pediatric imaging. Welcome to you both, and thank you for joining us today.
Glad to be here.
Thank you for having us.
Wonderful. We greatly appreciate it. Well, to jump in, if you could tell us how teleradiology has begun to play a more significant role in the delivery of services over the past few months, and which partners have been most affected.
You want to take that one first, Anthony?
Sure. So, well, certainly we've seen an increased use of teleradiology across our practice, all across the country. And that's been particularly important for a couple of reasons. First of all, a lot of our radiologists are much more concerned about coming into the hospital if they don't need to, for risks of getting infected. And so because of that, many of them have sought to increase the use of teleradiology, being able to read from their homes. In addition to that, we have had a few physicians that have become infected with the virus, however, have not become severely ill. However, if they're infected with the virus, they certainly need to quarantine in their homes. They need to stay away from others. And yet many of them can continue to work. And they've been able to do that by having workstations at home. And despite the fact that they're infected, they're still able to deliver patient care while they're at their home. In fact, we've shipped an additional 140 workstations to radiologists at home since the beginning of the many shelter-in-home orders that have hit most of the states in the country right now. So a lot more radiologists that are reading at home. One other thing that I think is important from a teleradiology perspective, although not directly related to reading at home, is the fact that a number of other clinicians, non-radiologists, appreciate the fact that they're able to access images remotely as well. Being able to have tools that allow them to see images because they may be reading, or not reading, but working from a different location. They're doing a lot more telemedicine right now, seeing patients that aren't coming into the office, perhaps not working from their normal office, and having access to those images has been important.
Those are all excellent points, and that's something we've done here. We're an academic medical center, so we tend to have a very crowded, busy reading room with lots of traffic, and very quickly, that does not lend itself to physical distancing at all. So we have pretty much taken all the PAC systems out of our reading room. We have an office suite across the street where everyone's got their own office. So some people are in office, some people took their systems home, but as Anthony said, you can still deliver the same level of care and expertise even if you are remote. And while we haven't had any of our physicians, our radiologists, have a positive diagnosis, we do have some older radiologists. We have some people with pre-existing conditions or on immunosuppressive medications, and the hospital's not the best place for them to be. So having that flexibility to keep them safe, but still being able to retain their talents and their expertise has been terrific.
Excellent. Well, now, Dr. Coley, I know that you work with some facilities that are in rural locations. Given that, that is something that you're accustomed to doing, how do you ensure that you are able to provide the pediatric imaging that is necessary? And particularly in this time where, COVID-19 is added on top of all of your concerns, what are you doing to make sure that you are reading in the most effective and accurate ways?
Well, so all of us are keeping up with the literature and what the findings of coronavirus might be, both obviously pulmonary manifestations, but new literature coming out with other systemic manifestations, particularly in pediatric patients. So the usual thing that every good radiologist does, keeping up with literature, making sure you're on the top of your game. Our partnership with the Radiology Partners Group has been very good. Their network is very strong, lets us connect to those hospitals that we partner with them to read pediatric studies from. The IT infrastructure is key, so we can contact those clinicians when we need to, or access the medical record if we need more detail while we're formulating our diagnosis. So some of that is honestly, it was already in place. I think the value of it and having a robust infrastructure that you can scale very quickly when you have a need like this has been terrific. So.
Yeah, absolutely. These Zoom video conferences are not just good for, office-based work or things like that, right? A lot of the people in different locations around RP have used these to share clinical information as well, which has been really effective. And especially having a large group of radiologists where we can collaborate quite quickly is really important, because the data on this is changing on an almost daily basis, where there's new evidence about new findings, new symptoms, and being able to share that very quickly is really important.
Yeah, I think an interesting thing that's going to come out of this, and we were talking about how we connect with our clinicians, is most radiologists have bemoaned one of the negative side effects of PACS is decreased clinician involvement. They're not coming down to see you, et cetera. They don't have to come see you. But there have been some very successful experiments at some places, Hopkins, NYU, my colleague Nancy Pfefferman, using sort of their own homegrown Zoom to have virtual clinical conferences and consultations. And I think, we're sort of seeing that. We bought some extra Zoom licenses when this all started to hold our teaching conferences. as well as just having some open lines for our particularly large service lines. You know, if you've got a musculoskeletal question, there's sort of an open Zoom line. You dial in, you get the radiologist, you can go over the images. So that's been something, now that we're getting used to this kind of interaction, I think that's actually going to be a positive coming out. I think some of that's going to stick. So the presence of radiologists potentially on rounds or in the clinic, we're all used to punching a button, whether we're using Teams or Skype or Zoom or whatever. I think this could be a positive thing that's going to come out of this.
Yeah, I completely agree.
Well, that actually dovetails into one of my next questions. Thinking about the long-term impact, is this, you know, something that you see kind of being adopted on a more permanent basis? Is that something that people are becoming very accustomed to?
Yeah, so building on what Brian was saying a minute ago, I absolutely think that some of this is going to stick, both clinically as well as from a business perspective. Many of our local practices around the country are accustomed to having board meetings where the physicians all come together into a group, and also having regional meetings where perhaps all the physician boards in the state of Ohio meet periodically. And they typically would do that in the past. They'd all get together, perhaps in a conference room at the hospital, and order some dinner, or maybe at a restaurant, and people had to drive a distance in order to make those types of things happening. Now, because of everybody becoming much more familiar with video conferencing, and because we have to do it this way, people are doing those same types of meetings via video conference. And they're saying, wow, why didn't we do this all the time before? This is saving us a lot of time. It's actually really effective. And so I think things like that will persist. Additionally, a lot of our hospitals, perhaps some of them where we've asked to have more remote type of work done in the past, and they've said, no, we really want all the radiologists on site. They're finding this actually works pretty well. We're getting a lot of subspecialty coverage from physicians that are perhaps in the greater area versus just being on site at one particular location. They're seeing that work well, and they're getting comfortable with it and saying, you know, there's no reason why we shouldn't just stay this way. We've also seen an uptick in hospitals that are using technology, perhaps PACS, where either the system wasn't able to support reading from great distances, or perhaps the hospital's IT group didn't allow it. They're coming to us saying, hey, look, can you help us create technologies where we can have more physicians be able to read at home, because this actually seems like something we might want to do, especially in the future, because it creates more resiliency in their kind of clinical platform.
Yeah, that's great points.
Well, obviously we're on a Zoom call right now. And so when we think about all of the benefits, on the flip side, are there any challenges or limitations to using this type of technology to facilitate the teleradiology that needs to be done?
Yeah, I think I don't think anything can really replace being there in person if you have that luxury. But I think, as Anthony, you know, is speaking to, there are a lot of organizations that, you know, just don't have the critical mass to have the kind of expertise that they still need and that their patients still deserve to have, just because you may be in a smaller environment or a more rural environment. So I look forward to when we can be in reading rooms together. I agree that video conferences are great, but there are social aspects. You know, we are social creatures. But I do think many of us, myself included, have been surprised at how effective this can be. I think especially with the video part of it, a lot of us are used to just Skype phone calls and those sorts of things, which are just terrible. I mean, they're distracting. I can't stay focused. I'm multitasking, all sorts of bad reading habits. With the video component of the technology, you know, you still have to, you still get a lot of the nuances, I think. I think the technology is so much better than it was even just 5 years ago. So, you know, it's a pretty acceptable substitute. And for a lot of places, it's the only thing that's really available realistically. And I think people are finding it's pretty good, really. It's really quite good. So I don't know how much we'll go back the other way, but there's no doubt there's going to be stickiness to this kind of interaction and this kind of teaming going forward.
Yeah, I completely agree. I think obviously there are certain procedural elements that cannot be replaced, at least not today, via any sort of remote technology. So that will always need to be there. And there's of course also times when radiologist needs to deliver a diagnosis to a patient or a patient's parents. And a difficult diagnosis is not easily done via video conference.
That is an excellent point. Yeah, I mean, delivering that kind of news, you need a human touch. You need really to be there. And so there will always be the need for on-site people to partake in that. Absolutely. That's a good point.
So then when we talk about those face-to-face consultations, be it between provider and provider or provider and patient and family, what are you both hearing about, I guess, any eagerness to get back to that or frustrations about not being able to have that right now?
You know, I think I haven't heard any particular frustrations about that or wanting to to rush back to the way it used to be. You know, there are so many uncertainties, and I think as this pandemic drags on, and we really don't know what the future is going to be. Are we going to have a second wave? I think people are anxious. There's a lot of uncertainty in their lives. Quite honestly, there's bigger things. I think, given how effective this sort of communication can be, in some ways, I think it's one less thing to worry about. You know, that's something I can still have the communication, I can still get information, I can still have human contact, and talk to my colleagues and peers and other experts. So I haven't heard a lot of frustration, to be honest. I think I've had people, I think, feel more grateful for their institution's bandwidth that they can actually, run these kinds of things effectively.
Yeah, exactly the same thing. We haven't heard anybody clamoring to come back into to get away from home, those that are able to read from home or read remotely.
All right. Well, then pivoting a little bit to thinking about what will be the post-COVID period, whenever we might get there. Some places in the country seem to be opening up a little bit earlier than others. But once your locations reach that point, do you anticipate that return to normalcy with, pulling everyone back into the office, having a normal staffing level and kind of going back to business as usual?
You know, we're just on the cusp of doing that. We've increased our operating room capacity last week, and we're in a phased ramp up here for the month of May. The ambulatory side of our enterprise, which had dropped to roughly 20% of clinical volume, the inpatient, since we're a pretty big tertiary quaternary center, that stayed roughly 75–80% volume during this time. So the ambulatory, the outpatient side, wants to get up to roughly 50% by the end of the month, and it's the usual things: screening people at the door, everybody wears a mask if you're in the hospital, physical distancing, the usual public health measures that everyone's talking about. And I think we can get to 50% without much difficulty. One of the things that's happened, we had a very good telehealth team that was just starting to ramp up, and we have partnered with Teladoc on a pediatric platform. Susan, I'm looking at my notes talking to my director there. So we were having roughly 70 telehealth visits a week pre-COVID. Last week we had over 6,000.
Oh, wow.
And I think that the people, the clinicians that were saying, oh, we can't do it this way. Well, you either do it this way or you don't do it at all. And when they did it, for the most part, it's like, hey, that was pretty good, and we can do a lot. So the impact on radiology is that getting to that 50% volume, our ambulatory team wants 2/3 of those visits to be virtual, which is great. That helps with their waiting rooms and their physical distancing. However, it's really hard to do imaging studies from home. So if we get to 50% from the clinical perspective, we're probably going to be at 70 or 80% of our volumes in radiology. And we've already had the the scenario where they've come in to get their imaging procedure because they have a telehealth consult in the afternoon. So they're going to go home and do their clinical visit from home, but they still have to come see us. So I'm most worried about the physical distancing. Basically, it sets up a very different sort of flow through our department. Our recovery rooms for anesthesia cases, we're not going to be jamming people in like sometimes we have to. So that's going to be more of a challenge for imaging because we can't take advantage of the physical performance of the examination as much. So that's going to be a challenge going forward to see how we handle that.
We're seeing very similar challenges from an outpatient imaging perspective. I think the other aspect of this is what to do for all the people who are not involved in direct patient care, the people who do scheduling, the people who look at insurance, all those sorts of folks. And right now, we have no immediate plans to bring those people back into our offices at this point.
Right. Same with us. All of our pre-op people and our coders, and even most of our informatics folks, they're able to work from home and be very effective.
Yeah, again, it's another area where I think we've experienced the same thing about how our clients doing telemedicine, it's actually proven to be a lot better than anybody expected.
Yeah.
I think for years, people have been saying, oh, this will never work. And not only did it work, it actually in some ways is working better. People are pretty happy with it.
Yeah, our patient family experience, surveys for telehealth, by and large, it's highly, highly favorable. It saves time, it saves, gas, it saves, all kinds of good things. And for a great many things, again, with the technology and the video capabilities, you get a lot done. You do a lot of things.
Absolutely. Well, like you said, Dr. Coley, your telehealth and teleradiology has kind of skyrocketed recently. Given that, are there things that kind of have emerged as, just, I guess, studies or various things that just don't work with teleradiology that are just better if you have the patient there with you to talk about, or if you're there at the hospital to read the scan?
I think it's actually very little, to be honest, especially if you have good communication with technologists with any questions. The obvious ones, ultrasound, especially in pediatrics, we do a fair amount of overscanning. So when there's questions or issues, it's good to be there so you can actually do the scans. As Anthony brought up before, talking to patients, talking to families, if they're anxious, a lot of times the technologists will say, hey, this is an anxious family. Can you come and, talk to them, at least give them a preliminary, certainly more limited if we're trying to do it like this than if you're just in the reading room and you can pop up and go, assure someone that their child doesn't have anything terrible going on. So, but honestly, for the most part, you can do an effective job of the interpretation as long as you still have these communication tools. So there's very little. As again, Anthony said, you can't do a fluoro study, you can't do interventional. There are certainly certain things, but for the most part, it's pretty good.
Fantastic. Well, you both mentioned certain challenges about physical distancing not necessarily being something that you can do when you need to have patients in to have a procedure or a study done. In the context of COVID-19, are you coming up with solutions to those challenges, or is that a conversation that has not yet begun?
In terms of what? I'm not sure I completely understood that.
Oh, in terms of patient safety and provider safety, once everything kind of opens back up and maybe you have more patients coming in, are there steps or strategies that you were already talking about to maximize safety and minimize the chance of viral transmission?
Well, I think like Anthony was saying, our outpatient clinics, last Friday, we rearranged our waiting rooms. So we got a tape measure and 6 feet is farther than you think, actually. And we started taking out chairs. We just did. We made some sort of family groupings for different sizes. We are limiting accompanying adults to 2 per patient. Again, in the pediatric population, we are much more likely to catch COVID from parents and each other than we are from our pediatric patients, as it's turning out, and certainly in our region. But we, took out chairs. We had our moving company that takes care of our hospital. They came and took out furniture. We turned our adjacent large conference room, which we had been using as a break room to help people distance when they're eating lunch, but we turned that into an auxiliary waiting room in case we need that capacity. So taking our schedules, stretching them out, having longer time slots, that's not as efficient, obviously, but it's it prevents queuing problems in waiting areas. We're probably going to have to look at running long rooms in the evenings, doing some more weekend hours to accommodate some of our backlog until we know we can start sort of bunching up and having people come in and be busier and more crowded. But It is possible. It requires a little bit of creativity and a little bit of flexibility on everybody's part, and that's been sort of the name of the game for whatever business you're in, for the last 8 weeks.
Yeah, we're doing a lot of similar things. Additionally, one thing that we found to be pretty effective and many patients seem to like, although not all, is the ability to do a virtual check-in where we're having people show up to the facility, check in via their phone, and then completing that entire process either via an app on their phone, text, or a phone call. And then when we're ready, when the examination is ready, texting them, telling them that now's the time to come in. We're also, of course, spacing out the waiting room as well, but giving the people the option to sit in their car until it's time for their exam has also been another thing that's been effective.
Yeah, I know there's some local pediatricians that have been doing that very effectively for their private offices. So we've been talking about doing that, especially our outpatient locations. That's not something we've done, but it seems to be very effective. And like you say, Anthony, some people are very happy, with that. They're comfortable doing all of that, and quite honestly, they appreciate that option. If they're particularly nervous and they want to minimize their exposure, then that's great. And that's a huge part about, we want people to come and get the care that they need, that their kids need. And so creating that psychological safety to come back in, whatever that takes, and anything to do with psychology, it's not a one size fits all. So having a couple of different solutions, I think is smart.
Yeah, absolutely. It's certainly patient concern is one of the things that's holding people back. And patients are making decisions on their own about weighing between the safety of potentially being exposed versus the need to get an imaging procedure done. And we're trying to make them feel as safe as possible because they do need that imaging care as well. So,
Right. Absolutely.
Well, you both have talked about how this telehealth and the remote consultations have worked better than anyone imagined that they would. Given that, is there a thought of making some positions permanently remote, and how will you make that decision?
Yeah, that's a really good topic. I actually had a discussion with the woman who's sort of in charge of all space planning here, and they're really thinking about that. And like Anthony said, it's like, I've got a lot of people that are working effectively at home. They seem to like it. Do I need all these cubes? Do I need all these offices? What's that going to look like? The social aspect of work is certainly part of it. I actually have a meeting tomorrow. One of the things we're looking at, being an academic institution, I've got a big new crop of fellows coming in July. And how are we going to do learning? How are we going to do training? Certainly a good portion of it can be done like this, but some of it can't, or at least we haven't been creative enough to come up with a solution to replace that. So how are we gonna do that? We're gonna have to have some physical contact, whatever distance or PPE that may require, but we're gonna have to do something. But I don't think there's any doubt that it's going to change. It gets into a little bit of, for us at least, I do have to consider a little bit of sort of team equity in who gets to read from home and who needs to be here. Because if you're on site, when you're at home, it's a different number of phone calls and interruptions, because even virtually, they're still going to find the person who's probably physically closest. So I think that's going to be a little bit delicate, because I don't want to create, the haves that they get to hang out at home and read from home versus other people that have to come in and deal with, the hospitals of the hassles of being on site at whatever clinic or hospital you're at. But there's no doubt that it's going to be a viable option. And for some of our older physicians, or for, again, those people that have pre-existing conditions, it may continue to be their best option for their health and safety going forward.
yes.
Sorry.
I agree with everything Brian said. I don't have a lot to add on that.
Okay. Well, then a last quick question, for this entire situation, what has been the greatest challenge that you have experienced?
Right, Anthony?
So I think for us, obviously, this was a huge impact to how we practice, a huge impact to us from a business perspective. And really, I think for us, typically we've been growing and doing a lot of really innovative things in radiology over the past several years at Radiology Partners. And a lot of that's been driven by this very strong sense of optimism, and it's all panned out. Everything's been good. We've done a lot of great things. And now we have been hit by this external force, which has dramatically changed the business. Volumes are significantly down. We're having to close imaging centers because patients aren't coming. And all that, that's all really tough. And it requires, I think, from a leadership perspective, really how balancing that sense of optimism, because I know we're going to get out of this. Things are going to get better. I think we're going to be even better than we were before, but at the same time, having the discipline to be prepared for the worst. I don't know how long imaging centers are going to have to be closed. I don't know how long before patients will be able to come back. And so balancing those two things has been probably the hardest part for me, because I tend to gravitate towards being optimistic.
Yeah, I agree with that. I mean, the obvious challenges of the physical operations and all the things we've been talking about, but I think for both departmental leadership, myself, for my role as, in our institution, and for leaders everywhere, it's managing the anxiety and the uncertainty. And I think Anthony said it really well, that balance of, I want to be optimistic, I want you to have hope, but there are some certain hard realities. Things are tough now. And I think also for physicians who are not used to having any sort of economic or job uncertainty in this country. That's a novel position. For people in business and lots of other industries, that's just part of life, but that's a really different thing for most people in healthcare. And also, I think, as this drags on, I think it's going to drag on for a little bit longer, certainly. People's home lives are tough too. Significant others facing their own job worries. I love my kids, but dear Lord, they're home all the time now, and I have to teach them math. And home is not necessarily a place of refuge and peace and emotional restoration. Home can be hard too now, and so I think going forward, as we lead our teams in different ways, having that heightened empathy, understanding what may be going on, behind the scenes, being aware of that, being kind and patient with each other, that's going to be as important in our recovery, in our getting back to normal, and reestablishing whatever our new normal looks like in our new relationships with ourselves. So I think that's a key thing right now.
All right. Well, thank you both, Dr. Gabriel, Dr. Coley. I appreciate your taking the time today. Thank you so very much.
Thank you for having us.
It's been fun.